Okay, good morning, everyone. First of all, thank you for the organizing committee for giving me the privilege and the honor to be here in this exciting event. I was given the mission of actually persuading the audience that CNS prophylaxis is indicated in the setting of histologically aggressive B-cell lymphomas, and that's what I'm going to try to show you in the next few slides. So, first things first, CNS relapse in histologically aggressive B-cell lymphoma, although uncommon, but it still is an established event or a sequel of the disease, and it confers a very poor prognosis where survival can be shortened down to a few months. The incidence varies between 2% to 6.4%, but we have to exercise caution when interpreting this data because, of course, it's always, as in the medicine world, it's a case-by-case risk stratification. There is a question whether rituximab had changed the way we look into CNS progression or relapse, and I'm going to show you this in a few slides very briefly. We'd have to bear in mind that the majority of CNS relapse happens in the brain parenchyma, and a small percentage happens in the leptomeninges, where more than half of those patients unfortunately present with a concomitant CNS and systemic disease, and this has a therapeutic impact on the way we actually approach our patients. It's no surprise to the audience that the data I'm presenting is largely retrospective or from retrospective analysis to prospective trials, but still the number remains overwhelmingly high. It is believed generally that the CNS relapse happens because of an interaction between the cytokine and the receptors, which actually alters the local immunity and causes a selective immune dysregulation. This had been suggested back in the early 2000s by a group of Japanese pathologists, and that had been published. As a starter, this does not include low-risk B-cell lymphomas because the risk of CNS is exceedingly low, and on the flip side, that does not include the highly aggressive B-cell lymphomas, where we know that the CNS risk is significantly high, like Burkitt's lymphoma specifically, and lymphoblastic lymphoma/ALL, where CNS is a default incorporation within their chemotherapy. There's limited data on high-grade B-cell lymphoma. It's a recently better defined category recognized by the WHO. We're yet to see more in the future, but what we have now is small numbers. So most of the data I'm presenting is from diffuse large B-cell lymphoma. And again, when it comes to C-cell lymphoma, which accounts for 10 to 15% of all systemic lymphomas, it's hard to really tease out big evidence, but it's not unreasonable to extrapolate the data from B-cell lymphoma to T-cell lymphoma. And there seems to be no difference in the way we approach HIV patients, not in the published infectious disease guidelines nor hematology guidelines. And for pragmatic reasons, more than 10% risk of CNS relapse is considered significant enough to actually contemplate offering CNS protection. Let me take you back in history to the late 90s, where MD Anderson Group had published an interesting retrospective analysis of more than 600 patients, showing us lots of, and they studied many, many variables of why those patients relapse basically the data of their relapses. Again, the French group in 2000 had analyzed retrospectively more than 900 patients who had actually received CNS prophylaxis, IT Metatroxate and high-dose Metatroxate, and they have made important observations. The analysis had shown that high LDH and extranodal sites remain the most important independent prognostic factors of CNS relapse, and IPI, the way we know it, shows you that if you calculate the IPI, that the low intermediate risk patients have had less than 1% chance, whereas those with a high intermediate, high to 4%. That does not only tell us that we need to offer CNS prophylaxis when it matters, but also this can potentially spare patients with low risk the hurdles of doing so. In 2009, Recover 60 trial had been published in 2008, and the reason or the trial was conducted to prove that there's no additional advantage of adding further chemotherapy to patients between 60 and 80 years of age. But the fact that some of those patients received rituximab incorporated within their chemotherapy and some of them didn't allowed us to observe that there had been differences between the two groups. Not surprisingly, 58 out of 1,222 patients analyzed have relapsed in their CNS, and again, in a similar anatomical fashion to what we know. Mostly parenchyma, and some of them meninges, and 5 of the patients had both. Only around a third of patients had been in remission when they relapsed in their CNS. However, more than half of them had the CNS progression or relapse on top or in the setting of a partial remission or a progressive disease. Although not very statistically significant, and I'll show you in the next slide, that the patients who had rituximab incorporated in their induction had 3.6% relapse, whereas those who didn't have rituximab had up to almost 6%. Not statistically significant, but it tells you something. Now, that makes us ask, who are the high-risk groups that we need to actually offer CNS prophylaxis? Is it anatomical sites? As we all know, primary testicular lymphoma carries a significant risk of CNS progression, and this had been demonstrated in an Italian study where they have found, at least retrospectively, that they were able to reduce the CNS progression risk from 20% to 6% by providing CNS prophylaxis. I believe in this trial it was IT Metatroxate. Now, thanks to the advent of more functional imaging and PET-CT specifically, we're capable now of finding lymphomas in previously uncommon places like the breast, uterus, ovaries, and so on and so forth. So the number of people identified to have breast involvement or uterine involvement remains small, but it's good enough to tell us that the risk of CNS is quite significant and exceeds the 10% cutoff that we have already established. There had been a historical, and in fact, even I think most of us, when we're practicing hematology over the past decade, there had been a historical notion that anyone with a craniofacial involvement, particularly sinuses, regardless of the stage, have had CNS prophylaxis as a default part of their chemotherapy. And in fact, this had been refuted in the study that I'm going to show you in a minute. And it seems that multiple external sites per se carries a very poor prognostic factor when it comes to CNS relapse. Of course, we all know Schmitz and group from the German group had published their important IPI CNS score showing us that the most important anatomical site was the kidney and the adrenals, as I will show you in the next coming slides. This had been a retrospective analysis by the German group for the craniofacial involvement published in 2014. And I wanted to focus on the C group, the bottom two curves, that shows you that, in fact, there hadn't been any statistically significant difference in the event-free survival and the overall survival between those who have had craniofacial, represented by the dashed line, and those who didn't, represented by the black line in the curve. So I think arguably, we should not be offering default CNS prophylaxis to those with sinus involvement. Is it the biology of disease? In the era of biology, genomics, and molecular profiling, it is a must question. So c-MYC translocation with BCL2, in other words, double-hit lymphoma or triple-hit lymphoma, is actually a highly aggressive kind of lymphoma. One would wonder about the CNS risk in those cases. Again, the numbers are small, but it's estimated to be anywhere between 4.5 to 5%, so it's kind of similar between the two studies, the Goya and the British Columbia Cancer Agency. Mind you, in most of those cases, patients present with already a disseminated disease where you would offer CNS prophylaxis anyway, regardless of biology. And also, mind you, that in younger and fit patients, you would usually offer a CNS-incorporated chemotherapy, such as McGrath protocol, Codax, or Hyper-CVAD. Schmitz and group in 2016 have published this I don't want to say game changer, but it was adopted by many centers all over the world, where they have incorporated kidney and adrenal involvement to their IPI the way we know it since 1993. And that shows you how significantly there's a statistical significance between those who had a kidney involvement in terms of CNS relapse and those who didn't. They had actually analyzed tons and tons of data in terms of B symptoms, bone marrow involvement, many anatomical sites, and have concluded this. So what they did is they incorporated the kidney and adrenal involvement to their IPI score and have basically proposed that those who score 4 and above are at significant risk of CNS relapse, of course, more than 10%. Hence, we need to actually offer CNS protection. Now, remember, make no mistake, this is not a perfect score, obviously, because it is observed, and we can see it in the practice, that patients who have scored intermediate still progressed in their CNS. Importantly, patients who only score kidney and adrenal maybe with age more than 60 or for stage, will still be intermediate and may not be offered if we follow strictly, dogmatically, the protocol. So it is important also to remember that the IPI, the way we know it, maybe 30 years ago now, does not take into consideration the number of extranodal sites, whether it's 1, 2, or 3, whereas there's overwhelming body of evidence telling us that more than 3 extranodal sites is definitely a high risk of CNS prophylaxis. Sorry, CNS progression. So, another question, high-dose methotrexate versus IT methotrexate. Of course, there's no robust evidence. You won't find randomized trials comparing the two. It's not apples and oranges, but also it's hard to prove that this is better than the other, but I'm gonna have to say the following. Lack of meaningful parenchymal penetration in the IT methotrexate makes high-dose methotrexate more of a preferred method of delivering CNS prophylaxis. In fact, some references say if you don't want to give high-dose methotrexate, don't bother. On the other hand, you'd have to consider the fitness and the organ function of the patient. You'd have to have good cardiac, nephro, and of course to withstand the volume. And in fact, this unfortunately can impact the systemic therapy at the end of the day. Now, dose and timing. Pharmacokinetics and pharmacodynamic studies have shown that the best plasma concentration of methotrexate is when it's given at more than 3 grams per meter square and with short infusions, 2 to 4 hours. So you'd have to keep that in mind to achieve the best penetration to the CNS. However, this should never be at the expense of the completion of their systemic therapy. And this had been debated in many studies. This was published in 2020, I believe, which shows you that, so what they did is basically they have squeezed in methotrexate in between their cycles, and they have also, the comparator group was end of treatment methotrexate, and it seems in this study that there's no statistical difference between cumulative incidence of CNS relapse, overall survival, or progression-free survival. Again, this had been addressed in the recent ASH last year, where the timing of high-dose methotrexate does not seem to alter the course of the disease, and in fact, the Forrester blot may actually suggest that it's better to actually delay methotrexate. I'm gonna have to say, at the end, it's that we're getting mixed messages when it comes to this. Because keeping in mind that the median time to progress into the CNS is 6 to 8 months, and you will give your patients probably a 6-month worth of treatment, then I'm gonna so you might argue that this may not be the best way to do, but it's also a more of a tempting thing to do because you ensure the completion of their systemic therapy. At the end of the day, the question is what the WH questions. So, who are we going to offer CNS prophylaxis? What are we going to use to protect their CNS? And when are we going to administer CNS prophylaxis? This is just a diagrammatic representation of how we usually do, and I take it from the British Good Practice article by Paula McKay. She suggests that for high risk of CNS relapse, of course, we don't routinely evaluate the CNS for any new run-of-the-mill diffuse large B-cell lymphoma, but we do if we have clinical suggestion. If we, however, believe that the patient is high risk, this means that they're either having high CNS IPI score, but that's not the only indicator. 3 or more extranodal sites, testicular involvement, renal, adrenal, or intravascular, which is intravascular diffuse large B-cell lymphoma, quite a rare variant of diffuse large B-cell lymphoma, and possibly breast or uterine, but we're yet to see more and more evidence to suggest so. And if your patient is fit for high-dose methotrexate, give them the chance. If not, I would say with a grain of salt, you may offer IT methotrexate because of the retrospective data that we have, and give them the benefit of the doubt. Now, fresh from the oven, we've been talking about circulating tumor DNA nowadays in the setting of primary CNS lymphoma. Bubilo and group from Spain, Barcelona, have actually studied this in the setting of systemic diffuse large B-cell lymphoma, primary CNS lymphoma, and concomitant relapses in 19 patients. And that represents 2 patients where it can show you, for example, in patient 16, that while the flow cytometry of CSF analysis was zero, unremarkable, the circulating tumor DNA looking for specific molecular aberrations had shown positivity, which may actually carry, let's say, it may pave the way in the future to actually non-invasively predict it's quite invasive actually because we're taking the CSF, but to predict the risk of CNS prophylaxis in patients who have completed their remission. Long story short, CNS progression in high B-cell lymphoma, although uncommon, remains a clinical unmet need, and we need to address this question with prospective trials if we can. And although this is lacking as we speak, I would say that there is overwhelming retrospective evidence that suggests we should actually take the effort and offer our patients CNS prophylaxis whenever feasible. So I would say it's always an individual physician's discretion. If you are able to save one life by offering CNS prophylaxis, then it is worth doing at the end of the day. And by that I conclude, and thank you everyone.